Members, we are talking about Department of Corrections today and how that relates to Medicaid. We're probably going to hear about some waivers that other states have done and what our Department of Corrections is doing. So without further ado, Mr. Castleberry, you are recognized to present to us.
Thank you. To begin with, I believe everybody has a handout in front of them that will provide a brief overview of just correctional health services and mental health services, and then I will turn it over specifically to Dr. Morgan, our Chief Mental Health Officer, to talk about what we're doing reentry-wise with severely mentally ill as it pertains to benefits, and was asked to also then wrap up with some comparatives from a couple of other state correctional entities who are accessing Medicaid in some innovative ways. So we will jump in with the first page or second page that talks about the health services overview for the Department of Corrections. The Department of Corrections is responsible for all healthcare services to those who are incarcerated, medical, dental, optometric, mental health services within the state's prison system. We have direct care services available at all 24 of our facilities. We operate 5 facilities which have 24-hour medical staffing. 4 of those facilities house infirmaries. The 5th one is where we locate our large segment of our geriatric population that have some aging needs, as well as our male mental health unit for the state. In terms of mental health, we operate 2 mental health units, one at Joseph Harp Correctional Center and one at Mabel Bassett Correctional Center. On the next slide, gives an overview of primary care services that were handled in-house by our staff. When you see medical sick calls or medical requests for health services, those are essentially the ways that the inmate patients request services for medical, dental, mental health, or the optometrist. They're essentially making an appointment to be seen. As you look there, the breakdown between nursing protocols, mid-levels, or physicians, our medical staff triage those sick calls and then make the appropriate assignment to which staffing level the individual patient needs to be seen at to begin the process of addressing whatever their concerns are. The number of actual individuals seen is always greater, normally greater than the number of requests. That has to do with our clinics operating much in the same way that your doctor's office or an urgent care does. We do have the ability during normal hours to allow for walk-in appointments. We also require if you are in one of our chronic clinics that you must be made present to be seen at least twice per year, so those are outside of the normal realm of setting up an appointment or a request that the individual patient requests. And the mental health numbers are also geared off of our mental health levels, where our mental health staff are reaching out to anybody who may be in the population who need to be seen. On the next slide, off-site and specialty care. When the needs of the patient exceed what the staff are able to provide in-house, the inmates are sent out for treatment services. We have one of 3 general descriptive ways that occurs. We do have a partnership with a rural hospital in Lindsay, Oklahoma, where there are 22 inpatient beds. They have the ability to provide emergency room services as well as some routine surgical procedures such as colonoscopies, and they have been able to bring in certain specialties at different times when the population needs are such that it is economically feasible for them. DOC and OU Medical Centers partnership, which Mr. Dowell will speak about a little more in depth. Of course, OU is centrally located. It's also the level 1 trauma center for the state. It's level 3 in terms of specialty care treatment for oncology, obstetrics, so on and so forth. So we have a lot of traffic that goes into OU for specialty care services. In the basement of the Presbyterian Tower, we have a full security complement that is assigned there for the needs of individual patients that are coming in to be seen, as well as exam rooms. Many of the exams for specialty care services occur there in the basement of Presbyterian Tower, but when it requires us to go to Dean McGee Eye Institute or Stevenson's Cancer Center, that security complement, along with the staff that transported the inmates, work to make sure that they are moving them safely and securely to those appointments that are not occurring in the basement of Presbyterian Tower. When we're unable to access Lindsay or OU, if OU services are scheduled too far out, or if there's just some other reason that we can't access there, we do have a partnership which is statutory through the Employee Group Insurance Division, where they establish a provider network for the entire Department of Corrections. If you think of it in simplest terms, individuals who are incarcerated are essentially covered by health choice. It's the same fee schedule. That was developed many years ago when the agency was apparently paying Medicaid rates and were struggling to find providers who were not in a network who were willing to see our client load at just the Medicaid rates. So the statute was changed. EGID developed the network schedule for us so that there is something of an incentive that exists for providers to see our patients across the state instead of transporting them all the way into the city if they happen to be located at Fort Supply or Jim Hamilton in Podo. On your next slide is a summary of FY19 Offsite and Specialty Care Services, which gives a general breakdown of the types of appointments that occurred. In terms of contracted providers, those would be those that are both in-network and out-of-network. Lindsay Hospital were those individuals that were seen at Lindsay. The 6,558 are those that went through one of the OU Medical Center specialty appointments, and then telehealth is carried there. Not that those individuals were seen off-site, but we do have telehealth capabilities, and the provider themselves are off-site. So we count those as off-site specialty care appointments, even though those 250 individuals did not physically leave the facility that they were seen in. The top 5 specialties is just a breakdown, not of the total above, but of the most accessed specialty services in 19. Orthopedics, of course, was the highest, and then a breakdown by whether they were seen in network at Lindsay or at OU. Then followed by radiology, Dean McGee, Eye Institute, optometric services, and just general surgery. Excuse me. On your next slide is where we'll specifically begin discussing Medicaid eligibility. Within the Department of Corrections and guidance from the Federal Centers for Medicare and Medicaid, we are able to apply for Medicaid eligibility when someone is inpatient hospitalized beyond 24 hours. That's the first hurdle that you must clear. Then you must look at the actual eligibility criteria. So that patient must be 65 years or older, or blind, disabled with a determined disability, or pregnant. There's a couple of other subcategory caveats, but they are very rarely accessed when we do those types of applications. So for any individual who is hospitalized beyond 24 hours, I have a central office nurse manager who manages those hospitalizations for the entire state. When we have someone who we believe is eligible by age or a combination of these other categories, she begins filling out the application for Medicaid eligibility determination, and that is passed off electronically to a specific individual at the healthcare authority. We have the ability on a case-by-case basis to turn those around on a fairly quick timetable. Sometimes there can be a lag in determination if the individual does not have the appropriate identification to prove that they're a U.S. citizen, but we also work to gain their birth certificate, Social Security card, so that we can ensure that the necessarily appropriate information is there for the application to proceed. At that point in time, once they are processed, that is a one-time eligibility. It is not for the duration of their incarceration. It is only for that hospitalization. For someone who may be determined eligible one time, if they leave the hospital and go back, we repeat the process. We must reapply each time. On the next slide, in FY19, we submitted 352 applications for Medicaid reimbursement on inpatient hospitalizations. 346 of those applications were approved. In terms of what that means in terms of dollars and cents, and I will tell you that for the FY19 Medicaid Savings, all medical billing for the Department of Corrections works very similar to yours and mine. There can be quite a lag time between when final billing is in and claims paid, so these numbers are not yet final. But the total amount that was billed to the Department of Corrections for the services that we requested Medicaid assistance for was over $9 million. Medicaid paid $2 million of that. DOC pays the state share. The healthcare authority pays first. We then reimburse the healthcare authority that state share for $800,000. Total DOC savings based off the total bill was in the neighborhood of $6.6 million so far. Now, if you do the quick math there and just do the subtraction, that will not total to the exact number. The reason for that is because of the arrangement with Lindsay. When Lindsay bills based on hospital billing code rates, it's different from the amount that we actually pay contractually. So there's a little bit of a variance there, in addition to the fact that all the claims have not been processed at this point. Now I'll turn it over to Dr. Morgan to talk specifically about accessing benefits with our discharging mentally ill population.
Hello. First, I'm just going to talk about some of the services that we provide and what we do overall. In DOC, our qualified mental health professionals consist of our psychologists, psychiatrists, social workers, social service specialists, and counseling clinicians. We provide a wide range of services from individual counseling, group counseling, crisis intervention. We do training for the facilities, also for probation and parole. With the psychiatric services, we have medication, education, and prescription. We also have more intense services at our mental health unit facilities, as he described earlier, and that's at Joseph Hart for the males and Mabel Bassett for the females. And at those units, it's an inpatient level of care. So it would be similar to what you would see in the community in an inpatient setting.
I'm sorry for interrupting. Can you please introduce yourself, even though Mr. Castleberry did that?
Yeah, sorry. I'm Jana Morgan, Chief Mental Health Officer for DOC. So at those mental health units, we do have more intense services. We also, through our partnership with the Department of Mental Health, we have a reentry program. And with that, they actually have integrated discharge managers that are housed in some of our DOC facilities. They are at the mental health unit facilities, as well as the Oklahoma State Penitentiary, North Fork Correctional Center, and Eddie Warrior Correctional Center. And those are where we have traditionally seen a higher number of inmates with severe mental illness. And those discharge managers help to coordinate and manage, along with our DOC coordinator of reentry services, helps to provide what services those inmates need, what they may qualify for, where they're going, and how can we best assist. In DOC, approximately 64% of the population, that's about 16,784 inmates at this time, have either a history of or are currently being treated for some type of mental illness. So that's a pretty high number. And about 23% are currently receiving some type of psychotropic mental health medication. When an inmate with severe mental illness is discharging, we like to look at about 6 months out to see what their plans are, what family support they have, what services they think they have. And again, our discharge managers, along with our facility mental health staff, work together to try to come up with a plan. We look at not only the mental health treatment that they need, but housing services they may need. And in addition, we look to see if they may qualify for disability, which also comes with Medicaid. When we believe that someone meets criteria, our DOC psychiatrists complete the psychological evaluations, and along with the application for disability for Social Security, the discharge manager submits that packet, and then once that's approved, the inmates that have been approved, as soon as they discharge, the day that they discharge, they can go to the Social Security office and they can let them know they're out of prison and those benefits can get started. If someone has been in less than a year, they actually can be reinstated. So we don't have to go through the whole process of reapplication and doing the evaluation. In FY 2018, we submitted 182 applications and 118 were approved. And traditionally, Oklahoma DOC has had a very high approval rate for those benefits, ranging from 62 to 90%, which is really high, with the national average being only 35%. So with that, I will turn it back over.
Beyond what we're doing with mental health applications, there is one other area that's not in your handout that I'll briefly mention, and we'll touch on again as we wrap up. But we do mirror the same process for hospitalization applications when we have somebody who is eligible for medical parole, who may not have a valid home offer, who may need, because of their condition at the time, nursing home type placement. But it's very similar, and on a case-by-case basis, it is a very small number of individuals at this point in time. Next, the next few slides, we were specifically asked to talk about a couple of states.
But before you get into those waivers, while we're still munching on all of the data you just gave us, do any members have any questions? If you do, just raise your hand so I can get you in the queue here. I'm gonna kick it off. So what happens now? You kind of talked about what, your discharge for people with mental health issues, which are quite a few in our justice system. What happens to everybody else when they're discharged? What are they given if they have health issues or things like that? What are they given as they walk out the gate?
Let's skip to the last slide of the presentation then. We can do that. That's just where I decided to put the discharge information, but we did do an overview of just discharge as it currently stands.
Hold on to that.
Okay.
You mentioned getting the inmate on disability and how you've done that. Is there a gap? I mean, a lot of people, when they apply for disability, they get the determination that they're disabled, but then there's like a 2-year waiting period before they can get Medicaid care, right? So do you still deal with that 2-year lag?
No, once our benefits have been approved, that's usually all in place, and we haven't experienced that lag for those that we've gotten approval for.
Okay, Representative Lawson.
Thank you, Mr. Chairman. Just a general question. Could you explain to this committee and anyone that is listening, when a person comes into the Department of Corrections, what type of assessment, a physical or mental health assessment, is done on those folks?
So there are two sites really, excuse me, that anybody coming into custody with the Department of Corrections, males process through the Lexington Assessment and Reception Center, females go through the Mabel Bassett Correctional Center. Those are the two assessment reception centers for the state. That's where everybody begins their term of incarceration for assessment and classification. The classification piece of the shop is where all the sentencing documents are received, and there is a tool that is utilized to determine security points, which is where they initially determine at what security level and what facility they will begin serving their term of incarceration. On our side of the shop, when you're talking health, mental health, there is a full battery of health and mental health assessments that are done. We draw lab results to determine if there are any infectious or communicable diseases, HIV, AIDS, hepatitis C, tuberculosis, those types of screening are done. There are physicals which are done by mid-level and physician providers at both sites, and then Dr. Morgan's staff does a mental health screening inclusive of and up to a full battery psychosocial assessment if there is enough information that's gleaned to suggest that that needs to be done. We review any medical records or medications that are received from the county jails that come in with them, get full medical histories, and then begin the process of making sure that they're on appropriate medications and referred on to the physicians either outside or inside, depending on what the health conditions are that they present with at the point of reception.
You're recognized for follow-up.
Thank you, Mr. Chairman. So someone is now an inmate, and I'm looking at the medical request for health services, one of the statistics there. Can you enlighten me on what that triage or assessment looks like for someone who is currently an inmate? Who does that assessment and that exam to determine the level of treatment needed?
So initially, the sick call request is triaged in terms of what the individual patient, in their own words, is requesting. If that's, I have a rash, it itches, or I have a cold and I've had it for X number of days, or if I just need to be seen by a provider. Each facility with each shift, if they have multiple layers of shifts, will have a triage nurse who's collecting those at least once a day, sometimes twice a day, depending on the patient load and facility size, going through those and then setting up and scheduling appointments based on the information that's there. That can also include reaching out, because we have something of a captive audience, to the individual if the information appears to be incomplete, to just have them come on down to be seen as a walk-in. In terms of the triaging it specifically, those nursing protocols, we have over 80 specific nursing protocols that are detailed similar to policy form, which are treatment guidelines, for lack of a better term, based on the presenting information that may be requested. They can fall back to a treatment protocol and a nursing protocol performed. It also doesn't preclude that what is requested versus what is presented when they may see a nurse, that the nurse may not say, wait right here until I can get you into a provider and put you in the waiting room.
Okay, follow up.
Thank you, Mr. Chairman. Looking at the hospitalizations, it looks like in 19, there were 352 applications, 346 of which were approved. Do you have any insight, since there were just 6 denials, was there a commonality between those 6, or can you provide details on that?
I don't know that I have specific details on that, but our friends from the Healthcare Authority might.
So I processed the DOC applications for Medicaid eligibility, and the 6 that were denied were due to citizenship or the medical records didn't suffice.
Please introduce.
They didn't
Please
warrant
introduce
a
yourself.
disability decision.
Please introduce yourself.
My name is Rosalyn Carl, and I work for the Department of Human Services, but I am housed at Oklahoma Healthcare Authority, and I determine the medical eligibility for these applications.
Pro Tem Wright, you're recognized for a question.
Thank you very much, Mr. Chairman. I was just curious, I was wanting better understanding, and I may have missed this part of it, but did you say that Health Choice was involved in some extent, or is it just the Health Authority?
Health Choice is not involved. It was just a comparative in terms of the type of network that is established through the Employee Group Insurance Division.
Senator Haste, you're recognized for a question.
Thank you, Mr. Chairman. And I may have missed this, but we're talking about Medicaid, or is everyone at DOC goes through Medicaid, or are there some other reimbursement programs in place outside of Medicaid that you look at?
Not at this time. The only reimbursement programs are just through Medicaid. I need to back up. Individuals who may have veterans benefits, we do have a partnership with the VA statewide where they have reentry individuals. If they have somebody, we supply them with a monthly listing of individuals who have indicated at the point of reception that they were a veteran. We supply that to the VA monthly based on the projected release date so that they can begin the process of determining whether or not there are any benefits available, and then they come into the facilities to work with those individuals to make sure those benefits are in place prior to discharge. Beyond that, Medicaid is the only benefit allowance for those types of individuals, severely mentally ill or those that meet the criteria of 65 and older, just for hospitalizations.
All right, thank you.
Representative Ranson, you're recognized.
Thank you, Mr. Chairman. The slide that says offsite care and specialty care, I'm curious, is the treatment, is there proactive? Like if like you likened it to private, like Health Choice type of thing. Are the inmates available to access preventive care, like dental checkups and those types of things?
Part of the preventive care that I think you're talking about, I would liken back to some of our chronic clinics. We have chronic clinics for those that are determined to have asthma, hypertension, HIV, AIDS, which require the individual to be seen at a minimum twice per year by our internal providers. So there's the same mechanisms in place for checkups through dental, the number of times that mental health will be reaching out to make contact with those individuals during incarceration as sort of a checkup meant to be preventive, to make sure that if there's something that we need to get you out and seen for, that we attempt to do so.
Follow up.
Thank you. Then the next one where it talks about the most accessed, the top 5 specialty services, are those age-related?
It is difficult to draw that conclusion year to year. Certainly there is some age issues that are going on with orthopedics, but sometimes our chief medical officer uses an analogy that when you're talking incarcerated populations, take the chronological age of someone and add 20 years' worth of health conditions to them. Some of it is lifestyle choices. Some of it is lack of access to health care prior to them coming to a period of incarceration. So it's difficult to say that it is specifically aging. We do know that our population is aging, though, that there are more of those individuals who are over the age of 50 now than there were 10 years ago.
Representative Newton, you're recognized for question.
Thank you, Mr. Chairman. Thank you for the presentation. Interesting. Geriatric facility. Which facility is that?
Joseph Harp Correctional Center.
So how many?
You're recognized for follow-up.
Thank you, Mr. Chairman. I'm still on summer break here. So how many would you say, for lack of a better term, bedridden are in that facility?
In terms of bedridden, even with our geriatric facility, what you will normally see are not individuals who are bedridden, but those that are on walkers, wheelchairs, canes, crutches that need some assistance. Individuals who are bedridden are normally placed into an infirmary space, one of those 49 infirmary beds that we discussed.
You're recognized for follow-up.
Thank you, Mr. Chair. So there are no Medicare benefits for the elderly?
Age alone, if you are incarcerated and not in a hospital setting, there are no Medicaid benefits.
I want to
Care.
interject here. Will you please, because there's an exclusion when you talk about the exclusion to Medicaid and Medicare when you enter into the justice system?
So with Medicaid, which I will profess I am most familiar with Medicaid, not Medicare. With Medicaid, when you are incarcerated within the state, any state, that period of incarceration ties the state to being the payer of last resort. It's only in instances when they are outside of and being provided care outside of state custody that is where eligibility comes into play. And with Medicare, while there are similar criteria, Medicare itself is based on the amount of funds that an individual may have contributed at some point in time. Being able to access that eligibility is not something that we have specifically forayed off into as an agency.
Director Castleberry, will you just enlighten the members here? Is Medicaid terminated or suspended?
I believe, and I will look at my colleagues from the Healthcare Authority, but I believe right now Medicaid is terminated at the point in time of incarceration in the state of Oklahoma.
Okay, Representative Newton, do you have any more questions? Representative Rowe, you're recognized for a question.
Thank you, Mr. Chairman. Number one, it distresses me greatly. There's only 49 infirmary beds for the entire state correctional facilities. So that tells me that there's probably a lot of patients, a lot of inmates that could be cared for at the facilities if we had more infirmary beds to do that. But my question is, does the eligibility and payment system differ between the private correctional facilities and the non-privatized facilities?
I think we'll have to do some research and get back to you on that. We'll have to look into that.
Pro Tem Wright, you're recognized for question.
Thank you very much, Mr. Chairman. I'm wondering, and maybe the bottom line here for us today is, how do you see Medicaid expansion helping the corrections system, and how might that be a benefit?
I'm going to you're getting ahead of us. We're going to look at some waivers that other states have done. So right now we're just kind of noshing on the preliminary statistics that they threw out. So we will get to that point in the presentation. I probably shouldn't have stopped it in the middle, but I thought that we needed to stop for a second. Senator Quinn, you're recognized for a question.
Thank you, Mr. Chairman. Could you elaborate on the difference between our approval of benefits versus that of other states?
It would not be an apples-to-apples comparison. In terms of other states, what really comes into play specifically about the two states, Ohio and New York, that we'll talk about in a little bit, they are expansion states. So in Ohio's case specifically, most individuals who are discharging the system will be eligible, not on the eligibility criteria we talked about, but at least eligible for a time frame based on being at or below the federal poverty level.
You're recognized for a follow-up, but we will get to that.
Okay, thanks. Is there any significant differences in our approval process versus others? Is it the same, better, more lenient?
When I've spoken with my counterparts across the nation who are either expansion states or not expansion states, those that are not expansion states face the same or similar constraints that we do currently. The eligibility criteria is fairly well limited to those that are either discharging who are mentally ill and disabled or who are hospitalized beyond that 24-hour mark. Those who are expansion states, and it does depend on how expansion is done, can qualify a larger number of individuals who are either at a halfway house level. There is a way if you are in the workforce that you could qualify the same way as a flat discharge or flat timer could. But in terms of the numbers, they are radically different because of the size of populations, the average number of discharges, and then whether or not they are expansion or non-expansion states.
Okay, so since this is where you guys are heading, I'm going to cut off questioning right now. If you're in the queue, hold on to your question, and we're going to move into that part of the presentation. But before we do, what struck me is, the 24-hour period and who qualifies for that, which would be part of that population is the disabled population. I'm curious, what percentage of inmates are deemed to be intellectually disabled?
It's approximately 1% of the population at this time, based on our mental health levels that we do when everybody comes into assessment and reception. We determine what level of service need they have, and one of those is looking at those who have intellectual disabilities, so it's about 1%.
Thank you for that. So, Director Castleberry, you can go ahead and proceed, and since we're getting ahead of the horse ahead of the cart here.
Thank you.
Cart ahead of the horse.
So in our presentation, specifically, we were asked to look at what the Ohio Department of Corrections is doing and a new waiver that has been proposed by the state of New York specific to incarcerated populations. The next slide in our presentation is courtesy of the Ohio Department of Corrections. I had a couple of conversations with them last week about their current process. Ohio is an expansion state and managed care state. Their process, beginning 120 to 90 days prior to the individual's discharge, they have trained inmate peer facilitators, and those individuals are educated on the enrollment processes and what the available plans are within the state. Their job is not to assist in really filling out the applications or in choosing a plan for anybody, but strictly for education purposes. Once they have offered a class or in an individual setting, the education that they provide, the person that they are educating then can either opt in or opt out. If they choose to opt out, they are again re-educated on the federal requirement, the tax law around it, to encourage them to potentially enroll. During the enrollment class, there is staff that are at each of Ohio's facilities. They are health information technicians that are either fully or partially funded through the Department of Health in Ohio. And I believe, based on the conversation we had, that some of the funding that does that is actual Medicaid dollars who do the enrollment. The enrollment application now is online, but because of security concerns, doing it in a computerized fashion is not always feasible in a correctional environment. So the individuals are filling out by hand the application, and those HIT staff are entering those into the system. They have another complement of 5 to 6 staff who are administrative, who work in Ohio Department of Corrections Central Office who are troubleshooting any applications, any follow-up that is needed, and there is a data stream that flows between the Department of Corrections and the Department of Health that talks about the discharge date of the eligibility so that the Department of Health knows when to fully activate the Medicaid benefits based on discharge, and if those dates change for any reason, if someone's release is accelerated or decelerated based on behavior or any other mitigating circumstances. They did not give me specific numbers, but they do believe at the end, and similar to what New York is doing, that this will decrease the number of appointments that occur in emergency room settings or people who release without medications. At least one of the articles that we were able to find is that their Department of Health estimated upwards of $30 million in savings or cost offset just from a decrease in the number of individuals who had been corrections involved who would be accessing either the county jail or, accessing emergency room or other types of emergency services upon release. And that is Ohio in a nutshell. In terms of New York is a slightly different animal, and my counterpart in New York was out of the office from last week until sometime this week. So what I've gleaned here is specifically from their waiver itself. They have not enacted this process. It is something that they are applying for, but if they receive it, they will be the first state in the nation to gain Medicaid benefits for individuals 30 days prior to their release. The intent for that is that they hope to be able to do some in-reach services. The populations that are being targeted both in Ohio and in New York are those that have chronic conditions, severely mentally ill, those that you would anticipate being high users of services through an emergency department in a state. Being able to do that in-reach for that population, tying them into primary care providers either by telehealth or by phone so that those appointments are set up and they know where they would be going to, as well as discharge medications. The waiver in New York posted for public comment a week ago today. It has a 30-day respondent period, which is where they're at in their process. They do explain in the waiver piece that they themselves don't really have a full pipeline built for how information would exchange between the Department of Health and their Department of Mental Health. They do have the support of both of those agencies to undertake this process. They too are estimating savings to the state or cost offset to the state based on decreased access by this incarcerated population once they're back in the community through emergency room or emergency department services.
Okay, members, we're going to, are you finished? Okay. Director Castleberry's finished, so if you have questions, now's the time to jump into the queue. I have a question for you on this. So the 8th Amendment of U.S. Constitution guarantees the right to health care for prisoners, but when they get out, there's nothing. Is that correct?
I'm not sure I'm the appropriate authority to weigh in on the 8th Amendment, but
Well, it says that, so.
yes,
yeah.
that is certainly our interpretation of how it pertains to health care for incarcerated individuals. They have a right to health care.
Okay, from talking to your cohort in Ohio, this prison transition program they have, did your cohort talk to you about any benefits of their expedited enrollment for the state and inmates?
They specifically said at this point that what they believe is the chief benefit is for the overall state, not necessarily specific to the Department of Corrections, but the decreased access in emergency room services or emergency services, also being able to develop that continuum of care to link somebody back to someone in the community that they are returning to so that they have an appointment set up. Knowing that that's somebody that they have at least interfaced with briefly to know where they need to be, when they need to be there, to develop that continuum of care, to get their next prescription, so on and so forth.
Has it reduced recidivism rates?
They did not have any specific data that they could provide me on recidivism.
Representative Lawson, you're recognized for question.
Thank you, Mr. Chairman. In regard to discharge, looking at some stats here, 64% of incarcerated offenders have a history of mental illness. And then upon discharge, there's, I don't have the slide, but a case manager, a few people, small group that establishes a continuum of care for these people. What is the level of care, generally speaking, for the people that are discharged? Is that into an inpatient setting? Is that assisted outpatient? Is that some sort of community-based service?
It really varies. It's independent, or it's dependent on each individual person's needs. Very rarely does anybody discharge and need to go into an inpatient setting. Certainly not our goal. Has happened occasionally, but very rare. The people involved in our actual discharge and reentry program, typically we have a program called Ricket that's in Tulsa and Oklahoma City. And if they are discharging to those two areas, we have identified community mental health centers that they go to, so it's pretty streamlined for those going to those areas. It's a little bit more difficult for those going to the more rural areas because we have to do our research about what's available. So it really is individual, depending on what each person's needs are.
Representative Ranson, you're recognized.
Thank you, Mr. Chairman. There was a clarification made on Medicaid terminated versus suspended, and I've missed something there. What is the difference between the two?
So if someone was on Medicaid at the point in time they became incarcerated, that Medicaid is terminated for the term of their incarceration up until the point in time that we either apply for it at their discharge through if they have mental health needs and we're trying to establish benefits, or if they are hospitalized, we can apply again if they meet the criteria. But it is a temporary activation of those services. It again terminates once they are no longer hospitalized. Suspension means that their benefits are just turned off, but they still exist in the system and can be reactivated again minus the full application process.
Follow up.
So when you had said that it was better to do a different type of coverage in incarceration, that's in the place of Medicaid because it's terminated, is that correct? Let me clarify. They're still covered as far as getting the health care that they need. It's just not Medicaid covered.
Correct. The state is the payer at that point.
Thank you.
Representative Rowe, you're recognized.
Thank you, Mr. Chairman. The 64% that have the mental health diagnoses, does that include substance abuse inmates?
No, they may have a co-occurring disorder where they do have both, but no, that is just those with an identified mental illness.
You're recognized.
So, as a healthcare provider that has worked in one of your contracted facilities, I think we can all agree that there is substance abuse that goes on in spite of the correctional facility's best efforts. These inmates that we identify as substance abusers, do we attempt any kind of substance abuse counseling while they're incarcerated?
Yes. Through our programs division, we have partnerships with the Department of Mental Health and Substance Abuse Services where their agencies come in and operate a certain number of our substance abuse programs. And then we also have the ability through Dr. Morgan's staff, if it's a co-occurring issue, where our mental health staff address whatever those needs may be, as well as any volunteer organizations that may come in and offer supportive services through AA, NA, and a variety of those as well.
Follow up.
So, let's say an inmate's going to be discharged in 90 days, and we know they've got a mental health diagnosis. Is there kind of like a step down, or, I mean, do they go to like a different facility to start transitioning into public life and getting that follow-up set up? And are there, on these ones that you apply for the Medicaid that are transitioning out of incarceration, is there stipulations as far as continuing their mental health and/or substance abuse follow-up appointments?
So the answer to the first part of that is through a normal incarceration, the idea is based on behavior, crime, security points, is to step down and discharge from the lowest level of incarceration. Of course, individual behavior factors into that, as well as mental health needs that may require you to discharge from the mental health unit, which is a medium security facility, or from an infirmary setting, which all of those are at medium security facilities. Normally, if you don't have a wide variety of mental health needs and you have appropriately served your time in incarceration and there are no disqualifying crime types for which you've been convicted, you would move down to minimum or even community or halfway level and discharge from there. In terms of the second part of the question, in terms of being able to require someone to obtain services, and I want to make sure I understand this, are you talking about in the community after discharge?
What I specifically was targeting was that, okay, we're getting you signed up for these services, we're getting you signed up for Medicaid that will cover these services. You may lose your Medicaid, or you may lose whatever other benefit you may be receiving if you do not do these follow-ups.
So the handoff with the severely mentally ill is very much coordinated with a partner service in the community, so there's much more of a handoff that occurs there. The same is true with the partnership with the VA, where they're very much working to ensure that those VA benefits are where they need to be and that the individual is following up. For somebody who may have been determined Medicaid eligible for hospitalization, and they have left the hospital, come back to the facility, and are getting ready to enter the community, those benefits turned off again when they discharged from the facility, or when they discharged from the hospital. So there's not a requirement that exists for them to do once they discharge back into the community. If we're ready and we can talk about general discharge and what the agency does for discharge and how that compares to Ohio and New York.
We will get there. Let me recognize Leader David for a question.
Thank you, Mr. Chairman. I kind of want to go back to what you presented about Ohio and New York. It sounded to me like you were making the argument that that with these two examples, that if we had Medicaid expansion, it would prevent a lot of our inmates that were being discharged from prison from ending up in emergency rooms. And so I just wanted some clarification on that, because currently, while someone is incarcerated, they have medical care that's paid for by the state of Oklahoma, correct?
Correct.
Follow-up?
Follow-up.
And currently, it looks like on the mental health side or the disability side, we do make sure that if anyone has any disabilities, and it looks like we have a pretty good approval rating, that we get those benefits set up before discharge?
For a small segment of the population that meets the criteria for those two programs.
Okay, so let's go back again to the fact that they currently have medical care while they are incarcerated. So how is it, do you have some statistics to back up that argument that if we can get them set up on Medicaid before they're discharged, that it would save the state of Oklahoma money with I guess, that they're going to end up in the emergency room within that 30 days or before they could get a job when they're discharged?
Beyond what was provided, at least in speaking with Ohio and specifically from New York's waiver, and New York's waiver specifically says that they believe they'll reduce emergency departments' usage, hospitalizations, and other medical expenses associated with relapse and demonstrated improved health outcomes, including reductions in overdose and death rates. Their argument is that the same population that is discharging from facilities are those that likely did not have some type of benefits in place prior to coming into prison. But without being able to get in touch with someone specific from New York, I'm not sure if they're using Center for Medicare and Medicaid data to back that up, or if this is an assumption that they're potentially just making.
Thank you, Leader David. So are we right to assume that there is an increased cost to the system when inmates are released, discharged, when they're discharged, that they're seeking care, maybe in emergency rooms? I mean, are we right to assume that, and that there is definitely some cost there, or not?
I think one of the things I can tell you anecdotally when it comes to our case managers who are working with those to prepare them for release and reentry, some of the questions that are asked by our medical and mental health staff in terms of where are you returning to, and where we have individuals, we have the ability to discharge someone with 60 to 90 days worth of their medications that they're on. So we make sure that we have something of a continuum in place and talk with them about where they would be going to continue those services. Anecdotally, some people know who their family doctor were, others do not. Sometimes those referrals are back to county health departments or community mental health centers. And of course, the information that we're going off of is where the individual is telling us that they are going to reside once they discharge. And certainly there's the possibility that they can change their minds.
Okay, Representative Stark, you're recognized for a question.
Thank you, Mr. Chairman. My question is about substance abuse. How many would you say have substance abuse issues when they come in? Do we have medical detox? And how many are participating in the programs for rehabilitation while they're incarcerated?
So programs are not specifically something that's under the Health Services Division. We do track data in terms of participation and completion, but I can get you those numbers. I don't have those numbers. In terms of detox, we do have a detox policy for those that are received in from the county jail setting. If there's a need for some type of detox, we normally do those in an infirmary setting unless their symptomology is such that they need to be sent out and detoxed in a hospital setting.
So you guys have lots of homework. For the members, I have studies and things like that on Ohio. If you want me to send those, I will send those on to you guys. North Carolina also does a similar program. Senator Haste, you're recognized for a question.
Thank you, Mr. Chairman. This is related to the mental health part of it, which obviously is a huge issue here. But first of all, what percentage of the inmates, once they're released, end up becoming reincarcerated?
The recidivism rate for Oklahoma, the last data that I'm familiar with, is that we are at or under 25%. In terms of overall recidivism, it differs from males and females. It's lower for females, but that exact number I don't have.
You're recognized for follow-up.
Thank you, Mr. Chairman. And of the those coming back, are they still falling in the same percentage mental health as far as 64%? Is that still in the, of those coming back still fall in that 64% range for mental health?
So the 64% is a cumulative end of the FY number based on our mental health classification system. So those numbers can be fluid, but they were locked for the end of the FY for the population as they existed. In terms of a comparative for those that return to a period of incarceration.
Well, I can tell you with our program, the Department of Mental Health tracks data, and since 2007, we've had our collaborative program for reentry. And typically, the recidivism rate for those with mental illness is almost double what it is for the average person. But for those involved in our program, we have tracked that, and it actually decreases the recidivism rate back to the typical recidivism rate of the overall general population.
You're recognized for follow-up.
Thank you, Mr. Chairman. Okay, following again, this aspect of mental health. I want to ask you about some Smart on Crime initiatives that the Department of Mental Health, has put out, and, as we look at it from a funding standpoint. But 3 areas I want to mention and see if, from your standpoint, would this be impactful by helping to keep people out of prison? So those fall into number 1, expand mental health courts statewide. Another one in that is establish 2 new regional crisis centers. Those 2 areas, do you feel like those would be impactful in reducing prison population either originally or from a reincarceration rate?
Yes, I think any expansion of any services in the community would be helpful to prevent those with mental illness coming into the system.
Representative Newton, you're recognized for question.
Thank you, Mr. Chairman. Just to kind of clarify and follow up with what Senator Haste said on recidivism, is that based almost all on mental health, or is there some that are, not all, but those that come back, what % come back because of health-related?
I'm not sure that we've ever delved into the information that we had as to why they come back. The recidivism numbers that the state compiles are year-to-year return to prison, usually within a 3-year window of their last discharge. That's just kind of a national standard rule of thumb that most correctional entities will utilize. In terms of digging in as to whether or not there was a new crime committed, if it was a similar crime, a violent crime versus a non-violent crime, if it was substance related, I don't know that we have ever delved into the information that we have as an agency to attempt to correlate to see if there's a magic bullet that exists as to what causes that reincarceration.
And members, I just sent you a study from Ohio. It's a qualitative study out of Ohio. It's from 2018, looking at how inmates self-report, and they report that having the cost relief on health care was really important for them not going back in. So you can read the conclusion on that if you don't want to read the whole report. Representative Lawson, you're recognized for question.
Thank you, Mr. Chairman. Instead of doing several follow-ups, I'll try and do a part A, B, and C in this. And I'm just looking at the 64% that have a diagnosis, and I understand that that number is fluid. I'm not really going to harp on that. I understand it's fluid, but over half. Do we have any data to determine, or do we know, of those 64, and let's just, whatever that number is that a diagnosis that the inmate had prior to intake, or was that made at that assessment upon intake? Actually, we'll start with that.
That's inclusive of any information we're able to gather when they come into the assessment reception center, as well as any previous incarceration or anything that we also are observing ourselves. So it's inclusive of any type of treatment that we're aware of.
You're recognized.
Thank you. I'm just curious if, obviously we have a lot of our inmates who have a mental health diagnosis. Do we know of that population how many had some sort of health care plan, whether it was private or Medicaid, prior to incarceration?
No, we don't have any way of reliably gathering that information.
You're recognized.
Thank you. And then upon discharge, looking at the approval ratings that we have, it looks like the national rate approval for benefits is 35%, and that we fluctuate between 62 and 90%. Would you say that that is because just overall Oklahoma is not as mentally well as other states, or is that something different entirely?
I think it's different. couple of factors. First of all, we really look to see who we think meets criteria, so we don't put applications in for everybody. So other states, there are some states that do it different. They'll put applications in for a much more wide range of people that maybe do not meet criteria. So first of all, we look at that. Our psych evaluations are pretty thorough. Our feedback from Social Security is that they're, very well written, very thorough, and we have an MOU and a data sharing agreement with Social Security. So there actually are identified people there, some of them former DOC staff, that once they get the application and that evaluation, they actually can go into our system and look at the supporting documents in our record. So they really have a good way to assess the information and have a good idea of that person's functioning.
Deputy Secretary Kimball, you're recognized for a question.
Thank you, Mr. Chairman. Representative Lawson hit on a point there, and I wanted to make sure I understand it correctly. So when somebody comes into your custody, as far as treatment plan or medical record or background, what information do you have access to? How do you get that information? Where does it come from?
Normally, the information that we receive is what we receive strictly from the county jail. We do have an electronic health record that we've had for over a decade, so for those who are returning to custody, there is some information, unless it's already been purged, if it's beyond the HIPAA requirement to keep that data. We also have a data sharing agreement with the Department of Mental Health and Substance Abuse Services, so if we receive someone into custody that we believe or has reported that they have accessed services elsewhere, we can reach out to them and obtain records that way. Beyond that, we rely heavily on self-report from the individual as to where they may or may not have received treatment, and then we have to work through normal medical records means to request medical records, assuming that the individual is willing to sign the appropriate releases to allow us to do so.
Follow-up.
I'm not as well practiced as my counterparts here on the working group, but would you agree? Is that how that goes? Okay, thank you. That's putting the Department of Corrections behind the 8 ball and trying to provide appropriate care upon intake.
Certainly, the more information, the better.
So I don't see any other questions in the queue, but I have one. Oh, Pro Tem Wright does, and Senator Coleman. So let's talk about these waivers. And we know that both of these states, North Carolina is also one who's done a very similar thing. They're all expansion states. And this may be a question for the Healthcare Authority. Despite Medicaid expansion, is this something that we could innovate on and create our own waiver in spite of expansion?
Audra Cross, Legislative Liaison. So we have had discussions about the suspension versus termination classification for justice-involved populations and what that would look like. We know that there are roughly 29 other states that will suspend Medicaid rather than terminate. That number may have changed a little bit, but roughly 29. Some of those states do it with specific time periods, so they'll just suspend for 30 days or up to 1 year. Some of them, the other states will suspend for the duration of their time with the Department of Corrections, so there are a couple of examples that we could look to, but we are one of the states, roughly about 19, that will terminate Medicaid benefits upon a member entering DOC custody. And I do believe that we track, to Representative Lawson's question, we will track members who are terminated due to incarceration. So we actually may have those numbers for you, but I can definitely look into that.
And to my question?
Well, so to your question, we are looking into ways for reclassification of suspension of benefits versus termination. A state plan amendment, a 1115 waiver, what would that look like? That's something that, if given direction from state leadership, we could do.
Okay, following up on that. So if we were to get a waiver together, could we do basically what Ohio and North Carolina have done if if there's no expansion?
So if we move ahead with this, they will still have to meet our current eligibility guidelines. So they will still have to have a categorical relationship with a parent-child caretaker, a disability designation from Social Security. They will still have to meet one of those eligibility requirements that we currently have.
What if we were to change in our waiver the eligibility requirements for incarcerated folks who have been discharged? I'm just curious. Or would that be discriminatory against
Right.
everybody else?
So then you start targeting too specific of a population, and that's the CMS will not approve that. So we can't just go in and say this, that you're basically getting into the field of partial expansion, and other states have not been successful in their efforts for that.
Thank you for that answer. Pro Tem Wright, you're recognized for question.
Would you, first of all, would you repeat your names again so we could have that down just on our records here?
So I'm Audra Cross. I'm the legislative liaison for Healthcare Authority.
I'm sorry, your first name
Audra, A-U-D-R-A.
and last name? I'm sorry.
Social Security, no. So Cross,
Last name first, no, I'm kidding.
yeah, Cross, C-R-O-S-S.
Okay, thank you. Okay, so I think you all would agree, at least from what I'm hearing you say, that there's a gap or a problem with medical care, because many of these patients have been on medical care while they're incarcerated, and then they get out and you have a program to kind of help a little bit, but there's a gap there for medical care. Would you agree with that? I mean, I think that's what I'm hearing.
And I know that the disability has come up when you're talking about the gap and the lag. The population coming out of DOC who may meet a disability requirement, we still wait on the Social Security designation for that. And so that is where we see a lag, waiting for them to be designated by Social Security as disabled. If they don't have that, if they don't meet that criteria, we will see a little bit of a gap from them being discharged to being able to receive Medicaid benefits. It's not the 2 years. That's a Medicare gap that we see with disability and Medicare, but there will be a little bit of a gap between discharge and Medicaid benefits starting if we are waiting on a Social Security designation of disability for that inmate.
And if I could add to that, the Department of Corrections does send a data extract similar to what all other states do to the Social Security Administration. I believe we're either bi-monthly or monthly. I think we started monthly, and now it is now bi-monthly for all admissions and discharges from a correctional setting.
Okay, I've got three members in the queue. I'll give you a follow-up just a second. I've got three members in the queue. We probably need to stop and take a break. I don't know how many text messages I got last week from people saying, oh my gosh, we need a break. So members, keep your questions short, and we will go forward. So Pro Tem Wright, recognized for follow-up.
Okay, and follow-up in that regard, outside of the Medicaid possibilities for some people, there's still a gap, obviously, with some of the people who might not have any kind of health care after they get out of prison, and they've had health care while they're in prison because that's required. Is that not true?
I would say yes, that's true.
Okay, so...
You're recognized.
Sorry. Follow-up, please. So with Medicaid expansion, I think I heard you say that's a pretty small percentage of the overall population, and is expansion or a waiver of some type going to help in that area that much?
I think it's a smaller population if you're looking at it through the lens of the current eligibility criteria.
So in response to his question, so if a state were to increase access to health care to 138% of the poverty level, it would capture a lot of these discharged people. Is that correct?
Based on conversations I've had with my counterparts in other states, yes, at least for a period of time once they discharge.
Okay, Senator Coleman, you're recognized.
Thank you, Mr. Chairman. Of the 64% that have mental health issues inside the Department of Corrections, what percentage of that would you consider severe mental illness?
When we look at our mental health levels and we base our evaluation of severe mental illness off of that, it's approximately 35% of that are currently receiving ongoing treatment that we would consider severely mentally ill.
Follow up.
And if you would reiterate what I think I heard, there's no mechanism in place for a discharged inmate to continue to seek care. They're not forced or encouraged to continue to seek care. It's up to them, correct?
In terms of someone who flat discharges their sentence, there is no mechanism by which DOC can control or supervise. If they are under supervision, we do coordinate with whoever their supervising officer is to encourage them that they have services set up in the community.
Representative Ranson, you're recognized for a question.
Thank you, Mr. Chairman. All right, so back to what you had just said before as far as if a inmate is being discharged and there's no mental illness issue, there's no disability issue, they have health care coverage in prison, but when they get out, there's none. That's correct?
That is possible.
You're recognized for follow-up.
So then, if we were to do a Medicaid expansion, that could capture several individuals in that category up to the point of the 130% poverty level. So if they get out of prison, they get a job, then that could be a transition to the point where once they have a job, then hopefully they would be able to afford it.
Other states that have qualified discharging individuals through the poverty level, that does establish a continuum of care for them up to a certain point in time to where they're employed and begin to move financially beyond that qualifying instance where they have their own health insurance or whatever that may be.
Representative Rowe, last question, and then we're going to take a break. And you can have a follow-up if you need them.
Thank you, Mr. Chairman. So I had a couple of distressing situations when I was working at the Lindsay Hospital, in that we had a couple of inmates, I can specifically remember even the exact rooms they were laying in because it had such an impact, that deliberately violated their parole to come back to prison because they had diagnoses of cancers. That bothers me a lot, that somebody would choose to go back to prison just to get treatment for the cancer they could not get treatment for. So if we had some sort of an expansion that could possibly include these inmates that have had cancer diagnoses or some other devastating diagnoses that might not qualify because they're not technically disabled, they're not 65, could some sort of expansion include these inmates so they're not deliberately violating their parole just to go to prison and get treatment?
I think there's a lot of moving parts to that. Assuming whatever that expansion was in terms of what that eligibility criteria is, theoretically, there could be a safety net there, is probably the best answer that I could give you.
Do you have a follow-up? Okay. So we're going to take a short break. I know you still need to talk about discharge, which you've talked about a lot. So we'll let you finish that up when we get back. So let's take it's 10:20 now. Let's be back in here by 10:28. We're getting started again here. We're going to ask for the conclusion of Director Castleberry's presentation, and that's just the discharge part. And if there are any questions after that, we'll take care of those as quickly as possible and move on to our next presenter. You're recognized.
Thank you. So the last slide of our presentation talks about discharge procedures, which are just the general discharge procedures that occur with anybody who's exiting from DOC custody. There are some similarities to the two states that we've talked about, Ohio and New York, regardless of whether we are expansion or not. Discharge normally starts, the planning phase of it with a pre-release plan, a document that we have that is a summary of information that case management staff put together in conjunction with the incarcerate, that talks about where they're going to be living, if they owe any court costs, fines, and fees, if they're going to be supervised, which district that they would be supervised from. Also gets into information around medical and mental health. We begin this process normally 6 months prior to the projected release date because we know lots of things are moving during that time period. Where you think you may be living or planning to discharge may not be somewhere that you actually have the support that you need and can go there. So addresses can change, resources can change. Medical and mental health staff are looking to make sure that we attempt to put together some type of continuum of care plan. We have the ability to discharge individuals with 60, and we have done at times up to 90 days worth of medication that they're on. We make attempts to refer them back to either a primary care provider or a county health department or services in the community that they tell us that they are discharging to. It's rarely possible to get a provider to hold an appointment for someone who we say is discharging from prison, who may not have health insurance or benefits. That is unfortunately just the reality of the situation. And then at the date of discharge, when they leave, they go out with their discharge plan, packet of information, medication, medical records. We do a medical summary of records so that they have that with them, that they can carry with them to wherever they're going, unless they fall into one of those types of discharges that we've talked about that are a little bit different for those who may be medical paroles or who are severely mentally ill that have more of a wraparound service model to it.
Representative Marty?
Thank you, Mr. Chairman. Couple questions real quick. As far as the discharge process goes, is it not possible to start an application for Medicaid, if we're doing this 6-month process during that process, so we're not waiting till discharge? And if that was possible, if these folks have been incarcerated for years without a job, regardless of 40 cents a day, they should qualify for Medicaid based on the poverty level regardless, correct?
So I'll take the second part of that. So just meeting the federal poverty level does not qualify you for Medicaid. So they also have to have a relationship. So they either have to have that disability designation, age blind, disabled, child caretaker relationship. So just meeting the current federal poverty level, the 40 cents a day that you spoke about, will not qualify them for Medicaid coverage upon discharge at this time.
Follow up.
Is that unless they're a single parent or the disability?
So again, if they have that, if they have the disability designation from Social Security, or they are able to obtain it, once they get that, then they would qualify with the federal poverty level. So it's going to take both of those things in order for them to get Medicaid upon discharge.
I think you're talking about in terms of like male incarcerated people. What about females?
So also pregnancy would be an exception. If a person is discharged and they're pregnant, then the process for receiving Medicaid benefits is pretty instant. They would automatically be Medicaid eligible. We'd be able to start providing them care. So that is a subset of the population that would be an exception.
Your follow-up.
Thank you. Do we know the percentage of discharges to homeless?
I don't think we have a number that's specifically for that. Part of the discharge planning is that the individual is to designate where they are returning to. Sometimes that's to family members, mom or dad's couch, could be a residence that they owned, but that is something that our case management staff work with in terms of them designating that. But of course, once they release, sometimes that can change.
Yeah, one more follow-up.
One more question, a little different subject. When we get into providing medical care for the inmates and being able to see a doctor twice a year, I think, and I don't want to put words in everyone's mouth, but when we're talking about people with mental illnesses, that's not medical treatment, in my opinion. Would you agree?
So The specific part that I talked about as being seen twice a year is specific to our chronic clinics. That's a minimum that those who are enrolled in chronic clinics, hypertension, HIV/AIDS, they must be seen at a minimum twice per year. For anyone else, it's the same process in terms of our access to care. If they need to be seen, want to be seen, they make an appointment or they can walk into the clinics and be seen. For mental health, and I'll let Dr. Morgan speak, but there's also the process by which that our mental health staff are going to find those that are mentally ill if they're not accessing services at the frequency that we believe they need to.
Yeah, so for anyone with we call them the big diagnoses, like a psychotic disorder, bipolar disorder, major depression, they are actually required to be seen monthly by a mental health professional, as well as every 90 days by a psychiatrist for prescription medication. Other people that may have a diagnosis of just some type of an adjustment disorder, nothing that we see as severe, that would be, termed as severe mental illness, they're required to be seen every 90 days. But those that are considered severely mentally ill have to be seen monthly.
Follow-up.
Are there any statistics in states that provide more mental health, like maybe weekly or biweekly, 3 times a week? We know that if counseling plus medication instead of medication alone would help these people. Is there any states that do that in their correctional facilities?
I think every state, it just really varies. And even for us, if you're in our mental health unit, then you are going to be seen monthly, sometimes depending on your need, maybe daily, weekly, monthly. It really is very individual. The monthly is the least. I mean, that's at least you have to be seen monthly. We do have people that are seen weekly or more often. I don't know about statistics from other states. Again, it's everybody does things so differently. But the monthly requirement is pretty typical across the nation as far as that's what is the at least requirement.
Did you guys bring statistics on how much the Department of Corrections spends on medical care every year?
I can get you those. FY19, which just concluded at the end of June, we still have bills and claims coming in for July, so the entire year is not locked yet in terms of our overall medical costs.
Okay, if you could give us 18, if you've got it.
Off the top of my head, or the actual numbers?
Oh, I would like to have the actual numbers, but if you have a ballpark figure, that would be nice to give us some perspective on how much we spend as a state on healthcare in prisons. And we realize this does not count county figures. This is just state.
So FY18, the operating, so this is minus any payroll costs or private prison costs, but the operating was right at $43.5 million.
Representative Newton, you're recognized for question.
Thank you, Mr. Chairman. Could just repeat that last number for me, please?
FY18 operating for DOC healthcare was $43.5 million.
Follow-up.
Thank you, Mr. Chairman. So our goal is to get these people not to come back, correct?
Correct.
So how long, as far as months, do you think you would need to extend some help to them to get resettled into their new environment?
Are you talking post-release or pre-release?
Okay.
Yes, after the release, post-release.
I would honestly be making up a number for you. Certainly there's some evidence that supervision in the community, coupled with treatment services and other preventative measures, decreases the likelihood for recidivism. But in terms of a magic number as to how long that should be, I think you'll see anywhere from 6 to 9 months mentioned in different correctional recommended research, at least coupled with what other states are doing for supervision. As to what it specifically takes to get someone their feet on the ground, have them steady housing, employment. I think that's a very individualized case-by-case basis depending on the needs of the person.
Follow-up.
Thank you, Mr. Chairman. So what I'm hearing, excuse me, what I'm hearing you say that it's more mental problems than it is health problems.
In terms of what leads to reincarceration,
Yes, sir.
I'm not necessarily stating that in one direction or another, that those that come into incarceration come in because of crimes that they may have committed. What is coupled with that in terms of their mental health needs or their health needs that overlay that, co-occurring, or even now, you may hear the term tri-occurring needs of individuals, are just another overlay of the population that we serve.
Okay, are you done? All right, I don't see any other questions from members. Oh, Representative Stark.
Thank you, Mr. Chair. I have a question in that these numbers of how many sick calls, how many dental calls, how many mental health calls, what percentage of those are individual people versus one person calling 5 times?
They're not phone calls. They're a paper and pencil system. There can be duplications in the sick calls themselves. To what extent that occurs, those are triaged daily, so an appointment could be set or a walk-in could occur. Certainly those appointments are to be reflective of the actual number of people that are seen, but there is duplication in that because you could be seen multiple times for a variety of reasons.
Follow-up.
Do we track that?
The sick call process itself is a paper pencil process which is scanned into our electronic health record. What I can tell you is the number of appointments that a person has, but when we attempt to mine data from the electronic health record, there's not a way to collate all of the individual appointments that you had plus mine plus hers. It's not a database that's aggregating those numbers. They are medical files.
Follow-up.
One more. In my nonprofit that I was working with, we knew that 23% of our population used 43% of our resources. That's what I'm trying to get at. Do we know what percent of the population uses what percent of our resources?
Not within our existing data system, no.
Would it be safe to assume that the aged, blind, and disabled, are they still the cost drivers in the corrections as they are in the regular Medicaid population?
They are still the cost drivers, but how we've got at that has been not with what is provided internally, but what has been provided externally. So for those services that are billable services, either through lab, pharmaceutical, hospitalizations, we see similar curves with the Medicaid population, that beginning at age 50 all the way up to 80 and plus is where you have more aggregated cost per age group, but I can't get down to the individual level.
Representative Rowe.
Thank you, Mr. Chairman.
Please speak into the microphone as well as you can.
Looking at this, I can't look at him and
You don't have to.
looking at the offsite specialty care and who you have contracts with, do we have a contract with anybody for the inmates that need inpatient behavioral health services?
We provide the inpatient care at our mental health unit, so we do not contract that out.
Follow-up.
Once again, I have had some inmates that had came to our facility were in crisis where we have no mental health provider, so that seemed a little, to me, a step downward from what they needed. So if somebody needs inpatient mental health, they don't go anywhere.
So in terms of if someone is in crisis and they may harm themselves, which prompts a hospitalization for whatever reason, One of the things that then occurs is once they are stable, once their healthcare needs have been met in the hospital, they are then moved to an appropriate setting. So they may have been at a facility where they did not have a mental health unit, but they had mental health staff who were seeing them periodically, decompensated for some reason, and then we would move them from the hospital back into a mental health unit for evaluation and analysis for whatever led to the self-harm.
One more.
I can just remember having patients that were in crisis. They were hallucinating and, they were definitely in crisis, but they came to a facility where there's no mental health providers.
Yeah, I'm not sure where that would be because we have services at every facility. So maybe that was at a time where there happened to not be one, but we have identified mental health professionals at every facility.
Thank you, Director Castleberry and Chief Mental Health Officer Morgan, for your presentation today. I hope somebody from your office was taking notes because you had a lot of requests for data. So we would appreciate receiving that as soon as possible. Now we're going to move forward. Like I said, the Healthcare Authority, Lori Kahn, is not here, so we will move to the University Hospitals Authority and Trust CEO, Randy Dowell. And Mr. Dowell, even though I recognized you and told everybody who you were, I need you to introduce yourself.
Thank you, Mr. Chairman. Thank you, members. Again, my name is Randy Dowell, and I'm the CEO of University Hospitals Authority and also University Hospitals Trust. With me today, I also have Sandy Decker, who's our Administrative Director of Revenue Cycle for OU Medicine, Inc., the private company that manages the hospital. So I'm going to visit with you today just a little bit about the services provided to DOC by OU Medicine, Inc., our private partner, and also provide just a brief explanation of why those services are provided free of charge to the Department of Corrections. OU Medicine, Inc., again, is the private company that the state, through University Hospitals Trust, has leased operations of the university hospitals to. The OU Medical Center campus, which includes university hospitals, is about to celebrate its 110th anniversary this upcoming year. University hospitals have operated in a number of different names and arrangements under that time. We have operated as a standalone state agency with a state agency running the hospitals. We have operated with the university running the hospitals. University Hospitals has been a department of other state agencies, but we really didn't hit our stride until until the state leased operation of the hospitals to a private company. It was determined in 1998 that the legislature really lacked the expertise to successfully operate the hospitals, especially hospitals the size and complexity of OU Medical Center, so the University Hospitals Trust was created to go into business with a private company. The joint operator today, as I mentioned, is OU Medicine, Inc. They're an Oklahoma-based 501c3, so all the profits that are earned at OU Medical Center are retained here in Oklahoma and reinvested on the campus. With this arrangement, the state wanted to ensure that the mission of University Hospitals Authority and University Hospitals Trust continued to be carried out. And so there is a joint operating agreement between the University Hospitals Trust and OU Medicine, Inc. that requires the private company to carry out the statutory mission of University Hospitals Trust. So our statutory mission is threefold. We're to provide indigent care. Indigent care for the University Hospitals Authority and Trust is defined in statute as Medicaid, self-pay, or charity care, and DOC inmate care. The joint operators required through the JOA, again, to provide a base amount of indigent care of $41 million to $61 million a year in cost of indigent care. Appropriations from the legislature offset that indigent care cost to the private company, as well as paying for programs such as Level 1 trauma and other patient services. Our second mission is to support medical education on campus of the OU Health Sciences Center. We support approximately 1,185 residency positions at the University of Oklahoma through appropriations that we receive from the legislature. And the third and final piece of the mission of the Authority Trust and OU Medicine, Inc., the private company, is to support medical research on campus through legislative support to the University Hospitals Authority and investment of of our private company, OU Medicine, Inc. We, this last year, as most of you have heard, were able to get National Cancer Institute's NCI designation for the Stevenson Cancer Center. Only 2% of hospitals nationally have that designation, and those services are available to our DOC inmates. And I'll visit with you later about the number of inmates who we do provide services for with cancer. State statute requires the joint operator to provide hospital services without cost to DOC. The joint operator is allowed to reduce indigent care service levels, including services to DOC, if appropriations from the legislature are insufficient to cover the cost. However, University Hospitals Authority Board and the University Hospitals Trust boards have never allowed them to reduce expenditures for those purposes. As you heard earlier, OU Medical Center has a complex healthcare system. What they use us for at OU Medicine, Inc. is highly specialized cases such as general and cardiovascular surgery. All of DOC's routine deliveries of newborn babies are scheduled at Children's Hospital. There were 29 deliveries performed in FY19. 17 of those births are what we would classify as normal births. There were 12 out of that 29 who were classified with significant complications. For children with complications, Children's Hospital is one of only 2 Level 4 NICUs in the state of Oklahoma, Children's Hospital in St. Francis and Tulsa. Level 4 neonatal ICU is for children born less than 32 weeks of gestation, less than 1,500 grams or 3.3 pounds of weight, requiring life support, respiratory support, or with other serious complications. The legislature appropriated $7.5 million to University Hospitals Authority in FY19 to offset the statutorily required indigent care at OU Medical Center. There were over $100 million in costs of unreimbursed costs of care related to self-pay charity and DOC inmate care in FY19. The value of those services provided at OU Medical Center to the Department of Corrections at commercial insurance rates, so that is a rate similar to Health Choice, which is what DOC pays other hospitals, would have been $24.4 million. The value of those services measured at Medicaid rates would have been $6.8 million. OU Medical Center's costs associated just with DOC inmate care were $13.2 million for inpatient and outpatient services in FY19. These medical services were all delivered at zero cost to the Department of Corrections. So how does a patient get to OU Medical Center? The transfers and direct admissions are coordinated through our Patient Logistics Center. They assign open beds to the patient. For security reasons, we typically try to keep all DOC inmates, all federal inmates, county inmates on one floor. We have an end of a hallway on the 6th floor with enhanced security. There are other beds available in the hospital based on the level of care or the type of care. For instance, a cardiac patient may be placed on the cardiac floor so that the attending physician doesn't have to move between floors to see his other cardiac patient. Inmates in the ICU would not be on the 6th floor. And then again, labor and delivery services are provided at Children's Hospital. Referral sources come a variety of ways. DOC can send an inmate directly to the OU Medical Center emergency room or direct to an inpatient hospital admission. We get inmates from Lindsay if their care requirements have exceeded what can be provided at Lindsay Hospital. They either come direct to the ER or an inpatient hospital admission. And we also receive admits that DOC has initially admitted to a community emergency room. Once they're stabilized, they're then moved to the OU Medical Center emergency room or for a direct hospital admission. The patients are coded as charity or self-pay, and we verify the facility that they're coming from using DOC's website offender lookup. Thank you. OU Medical Center handled 366 inpatient visits for DOC in FY19. The average length of stay was 5.41 days. The average cost to OU Medical Center per visit was approximately $19,247. The severity of the cases is a huge contributing factor to the overall cost for us, and we'll talk about some of that in just a few minutes. If you look, this is a breakdown of the numbers that I gave you previously for inpatient and outpatient. It's broken down. These are just the inpatient equivalent services. So DOC, another facility would have received $4.2 million from Medicaid for these services, $6.6 million from Medicare, and $15.7 million from commercial insurance. The complexity that we spoke about a few moments ago, it contributes greatly to the value of the care. The age of inmates is a contributing factor due to comorbidities. We had 53 of our 366 admissions that were inmates over the age of 65, another 82 who were between the ages of 55 and 64. So our case mix index is how we measure the complexity of the care. It's based on medical severity of the DRG code divided by the total number of discharges. For OUMI, for OU Medicine Inc. system-wide, our case mix index in FY19 was 1.7. National Council of Teaching Hospitals median CMI is 1.88. The CMI for DOC-specific patients was 2.1, which is 24% higher than the system aggregate, which includes the Level 1 Trauma Center. So the care that we're providing is extremely complex. If you look here on the inpatient services provided, you can see that the largest service provided is general surgery, followed by general medicine, cardiovascular, neurosciences, OB, oncology, and orthopedic spine. Moving on to outpatient services, we also receive inmates in a number of ways for our outpatient services. Primarily, the referrals come from the DOC facilities, the resident clinics, or from the Lindsay Hospital. Surgical cases for outpatient are scheduled with our operating scheduling department. Outpatient diagnostic studies are scheduled with central scheduling, so we get a call or a fax from the referring facility. They're placed on the schedule. Most of our outpatient clinics for DOC take place in one building. They are not over in the regular adult clinical building. They're on a floor of the physician's office building next to OU Medical Center. And so DOC arrives daily with around 15 to 20 inmates for outpatient visits in that area. The physicians leave their other clinics to come over to the DOC clinic and provide the required services in that particular area. OU Medical Center provided 4,718 outpatient encounters for DOC inmates during 2019. Again, those services are somewhat limited due to the location of the clinic in the physician's office building. Similar to inpatient services, we provided fewer overall outpatient encounters than what other facilities in the state did for DOC, but the cost of care at OU Medical Center, because of the complexity of the specialty, was significantly more. The equivalent outpatient charges under Medicaid reimbursement would have been $2.6 million, under Medicare $3.8 million, and under commercial insurance $9.7 million. The types of outpatient care that we provided, sorry, those numbers are a little small up there, is outpatient surgery, general surgery is the largest category, over 1,600 procedures performed, emergency room transfers from DOC or from other facilities, general medicine, OBGYN, cancer treatment, including radiology, chemotherapy, and neuromedical services at the Stephen Cancer Center, CT, MRI, ultrasound, ORL, gastro, and all other. So the numbers presented here really do not include DOC's other healthcare costs. They have significant costs in transporting inmates to OU Medical Center from across the state. Typically for an outpatient visit, they provide one security guard per inmate for a minimum security prison, up to 4 correctional officers per inmate for a maximum security inmate. So when you come to that outpatient clinic that I mentioned, there are oftentimes significantly more DOC security personnel in the room than what there are inmates. So they've got some substantial costs, even though we're providing those hospital services for free. What is not provided free for them on campus is physician services. The physicians are not employed by the hospital, so they do also receive some billing from physicians that will have been included in the data that Mr. Castleberry provided. That concludes my overview. If you have any questions, I'll be happy to answer them.
Thank you very much. Senator Haste.
Thank you, Mr. Chairman, and appreciate the presentation. Going back to slides 5 and 7, at a hospital, you're going to have a list price, and then in descending order, you'll have reimbursement rates at self-pay, commercial, Medicare, then Medicaid. Okay, you mentioned 2 numbers here. One, the $100 million of unreimbursed dollars there on page 5, and then on page 7, the 19,000 and change is the cost related to a patient, average cost there. In both of those cases, what is, so we're at apples to apples comparison here, are those numbers based on list price, or what are they based on?
Those are the actual cost of services using our cost to charge ratio, which is audited by CMS annually. So the $100 million in cost, that would have represented over $500 million in charges at a cost to charge ratio of, around 15%. So those are the actual costs incurred by the hospital for providing those services.
Follow up.
Thank you, Mr. Chairman. And the same thing on the $19,000, that's actual cost?
Yes, Senator, those are actual costs.
Thank you.
Senator Quinn, you're recognized.
Thank you, Mr. Chairman. Is there a reason that we have self-pay and charity included together? Are they coded the same, or is there any particular reason it's listed that way?
Mm-hmm. Because they're essentially the same. We had around $540 million in charges for self-pay in FY19. We received about $1.2 million in payments towards that $540 million in charges. For the most part, OU Medicine, Inc., we have a financial assistance program. Any patient whose family income is under 200% of the federal poverty level, if they fill out the financial assistance form, they receive a 100% discount on their hospital charges. So self-pay originally, so people are going to come in as a self-pay. If they're below 200% of FPL, we're going to write off 100% of that cost.
Follow up.
Away.
Representative Rowe, you're recognized.
Thank you, Mr. Chairman. I just wanted to clarify on, I'm not sure what page it is, when you're talking about the $100 million of unreimbursed cost on the self-pay/charity and DOC. So DOC does not pay OU for inmate care, is that correct?
That is correct. They pay us for no inpatient hospital services.
Follow up.
So does the Medicaid for the hospitalization greater than 24, does that not apply to OU?
It has not historically applied to OU. We receive no Medicaid reimbursement for any DOC inmates who are admitted or discharged, inpatient or outpatient, from the Department of Corrections.
You're recognized for a follow-up.
So who pays then, say for instance, the cancer clinic or the HIV clinic? Who pays for that care? Is that a write-off also, or does DOC pay for that?
So University Hospitals Authority and the joint operator are responsible for acute care, not chronic care of an inmate. So DOC bears the cost of the HIV clinic and the hepatitis clinic.
Follow-up?
Thank you, Mr. Chairman. So back to the cancer thing, I know that, say, for an insured patient, there are avenues from some of the drug companies, and as our fellow representative who's a pharmacist can attest to this, these drugs are very expensive. So on these inmates that are requiring chemotherapy that cost a lot of money, are there still avenues from the drug companies to help offset the cost of that, or is that only for insured patients?
OU Medical Center is a 340B hospital. We receive steep discounts on our medications as a 501c3 not-for-profit. So if an inmate is coming in for an infusion of chemotherapy, that is provided at OU Medical Center at no cost to the Department of Corrections. The hospital then bears the cost of that drug on behalf of the Department of Corrections.
Representative Ranson.
Thank you, Mr. Chairman. Back on slide 3, sorry, I'm having a hard time saying you myself. You had thrown out a number range, 41 million to 61 million on that slide. It wasn't printed on that slide, but you had brought that forward. I'm wondering, how does that range play with the other totals you gave out?
Thank you. So the $41 to $61 million was a negotiated amount of indigent care that was built into the joint operating agreement with OU Medicine, Inc. The hospital provides substantially more than that. Essentially, they are allowed, if they provide more than that amount, to request of the University Hospital Authority to come and make a request for additional funds from the legislature to offset costs of indigent care. That is, the hospital has routinely operated for the last 15 years at well above the minimum required in the joint operating agreement, and University Hospitals Authority traditionally has not requested additional funds for that. Our $7.5 million is the amount we received the last 2 fiscal years for that. In FY20, we did have a small pickup due to a change in the FMAP. We were very grateful. The legislature allowed University Hospitals Authority to keep that pickup on the FMAP. All of that pickup, the extra $1.5 million, was put over into the indigent care line. So for FY20, University Hospitals Authority OU Medical Center will receive around $9 million instead of $7.5 million. We work with the Healthcare Authority on those funds to maximize federal dollars. Like all hospitals in Oklahoma, we have an upper payment limit mechanism. We are not under the SHOP program that you're familiar with for other hospitals. When the legislature was creating the SHOP program and the Healthcare Authority was doing the modeling, because of our volumes of Medicaid and uncompensated care, we would have eaten up most of the SHOP pool. So you would have had rural hospitals paying in, but getting less back than what they were paying in, because all of the funding would have been siphoned down to OU Medical Center. So we were put in a separate pool, called, the pool is for level 1 trauma centers. And so our supplemental payment to get us from the regular Medicaid rate to the upper payment limit, we use these funds as state share to get us part of the way there. Our supplemental payment for FY20 should be around $160 million. That's just on the Medicaid care. Just by reference, all other hospitals under the SHOP pool generate about $450 million, just to give you an idea of the magnitude of the Medicaid care that goes on at OU Medical Center. But this $100 million, I did pull that out as in the definition of indigent care. It does say Medicaid self-pay and DOC inmate care, and for that $100 million, I pulled Medicaid out of that calculation. So The $100 million, I can't see my slide numbers around the camera. That $100 million is just self-pay charity and DOC.
Follow-up.
So when you say that state appropriations, 7 million plus, then that is, they're matched federally? What is the match?
We would get around $15 million or so of federal funds on that match of $7 million.
Okay.
I don't see any other questions. If anybody wants to get in, you need to let me know. So, okay. One thing that really, I saw him, but I'm going to ask some questions. One thing that stood out to me was your complex cases and the high CMI, higher than the median of 2.1 for Department of Corrections patients. What explanation is there for that higher CMI?
So part of it is the age of the patients that we're seeing. So the CMI for the hospital overall, our system CMI includes Children's Hospital. So, you know, there are most definitely very complex cases, but there are a lot of routine cases as well. So with DOC and with the age of the average age of the inmates that we're seeing, it's very complex care. And again, DOC is sending their routine care inmates. If someone has an arm fracture or a minor infection, they're going to go to Lindsay Hospital. The patients they're sending us are the patients that Lindsay does not have the services available, either the specialist, the surgical expertise, or the treatment for cancer, you know, the infusions and other things. So it really is just the types of patients DOC sends us.
Okay, so the 53 cases you had that were 65 and older, were those billed out to Medicaid after the first 24 hours?
They were not. That's why I separated those out in the PowerPoint. So the normal process for applying for Medicaid coverage for a DOC inmate is for DOC to send that application to DHS and the Healthcare Authority. We have we're not sure what the barriers have been in the past. We've talked to Clint, I've talked to the Healthcare Authority. Historically, we have received no Medicaid reimbursement for inmates that DOC sends to the OU Medical Center, either the prior joint operator, HCA Health Services, or the new joint operator, OU Medicine, Inc. We're very eager, and I believe the Healthcare Authority has expressed an interest in solving that problem.
Yeah, absolutely. So we
Introduce yourself again.
Do you want me to spell my name too? Again?
Yes. No.
So Audra Cross, Healthcare Authority. So we went back and looked at some of this data a couple days ago. So we receive notification from DOC when an inmate seeks care beyond the 24 hours. So we have record of that, but we actually don't have claims from OU. So we are having discussions around why that is, and I think they're becoming fairly productive. So we're trying to figure out what the holdup is, but we pay claims to Lindsay. We pay claims for those members who are eligible in this justice-involved population, but for whether it was the previous owners or not submitting the claims, but we actually do not have claims submitted from the university or from OU Medicine for us to pay at this point, and we are trying to figure out why that is.
But it just really makes sense that should happen, because we could offset some of the cost of the indigent care that OU is treating, and they can make their money go further. Pro Tem Wright.
Thank you very much, Mr. Chairman. I'm wondering on your indigent care medical research, when a inmate is discharged, do they continue, I would think, or at least they would be eligible for some of that care if they fall into that category? Is that correct?
When an inmate is discharged from OU Medical Center, no. Well, yes. I'm following you now. Yes, as I said, at OU Medical Center, our commitment to indigent care through the Authority Trust and the joint operator, our financial assistance program, we do, if individuals fill out the appropriate forms, we will provide a discount for individuals up to 200% of federal poverty level. Typically, that discount is 100%.
Any other questions from members? Seeing no further questions, thank you, Randy, for your presentation. Thank you to all the presenters. Thank you for everybody who's here today. I want the members just know that from here, be prepared to spend all day here because our meetings will be much more lengthy. Senator McCourtney sends his regrets that he couldn't be here. He's at a conference in Chicago. So we will see you all next week at 9 a.m. Again, thank you to everyone for coming, presenting, and participating. This adjourns the meeting.